Hello, everyone. Very good afternoon and very good evening to all our colleagues who are here to participate in today's webinar. So today's topic is pearls in pediatric extracorporeal oxygenation. And we are very fortunate to have our colleagues from Thailand who will be sharing our knowledge with us. Today we have two speakers. We have Assistant Professor Tirapong, and who will be speaking to us on the topic of ECMO in pediatric cardiac surgery. He'll be talking about what's ECMO and from initiation to weaning. And Prof. Sunirath, whom many of us know, she'll be speaking on the topic of application for ECMO in pediatric surgery on perioperative eCPR. The moderators today are me. I'm a consultant in KK Women's and Children's Hospital with interest in pediatric cardiac anesthesia. And I would confess that ECMO is a topic which I'm keenly interested in. And along with me, one of my co-moderators will be Dr. Angela Tan, who will be joining us shortly. She's also a consultant with me in the same hospital, and she has keen interest in pediatric cardiac anesthesia and also in education. When it comes to the vision of our cardiac SIG, which is under ASPA, it's a platform where we'll be sharing insights and expertise to enhance standards of pediatric cardiac care in our region. To sign up, you can look into the QR code. So as per today's topic, so I was just looking into the ESLO database. So if we take off the last 5 years, where a lot of ECMO has been in patients who have had COVID, there are about reported cases of about 120,000 patients going on ECMO. And to me, it was insightful to look into it that about half of them are actually in pediatric, including neonates and pediatric patients. They're divided in those going into pulmonary, cardiac, and having eCPR, and they form about half. So we all know that pediatrics form about 10% of all anesthetics, but they form about 50% of patients going on ECMO. So it's a topic which anyone who's taking care of pediatric patients will probably come across more than if they're doing adult patients. And it's a topic probably someone not even doing cardiac anesthesia should be aware of. So thank you. We'll thank our speakers here who will be sharing us in the wide range of topics. So first, as I said, will be Dr. Tirapong, who will be sharing us widely about the ECMO in pediatric cardiac surgery. And so he'll be talking to us about what is ECMO and from initiation to weaning. So we'll have a Q&A session. So you can send your questions in the Q&A function. Chats and raise hand will be disabled. Our moderator, which is me and Dr. Angela, will highlight the questions to the appropriate speakers. And at the end of the 2 sessions, the panelists will be answering your questions. There'll be some poll questions, and you'll just have about 30 seconds. And the speakers will, at the end of the poll, will be sharing the results. The speakers will explain about poll questions during the talk. The certificate of attendance, there'll be a QR code at the end of it where you can access the MCQs and the survey forms. The certificate of attendance will be forwarded after you successfully submit the MCQs and post a webinar survey. Please ensure that you're correctly keyed in your full name and also your email address. Don't worry if you miss the QR code. It will be mailed to you tomorrow by 5 o'clock Singapore time. If you are not able to fully attend today's meet, you can go to the YouTube channel and search in ASPA Flex. You can also visit our website, aspa-2000.com, and please like us on Facebook. So starting with our first poll question, as I said, only 30 seconds. So in pediatric cardiac surgery, which factor is considered a relative contraindication to the initiation of ECMO? You have 30 seconds to answer. This is a single choice question. Okay. So the answer is severe coagulopathy. Professor Tirapong will explain a bit more during his presentation. We'll move on to the next question. In pediatric patients undergoing ECMO with a systemic to pulmonary shunt, which of the following strategies is typically employed to manage excessive pulmonary blood flow? Again, it's a single choice question. These are the poll answers, whereas the correct answer is C, which is shunt restriction or occlusion. So about 23% of you got it right. So I'll briefly introduce Professor Tirapong. Professor Tirapong is Assistant Professor in the Division of Cardiothoracic Surgery in the Sri Raj Hospital. He's a Faculty of Medicine in Mahidol University, Bangkok, Thailand. He's done a fellowship in pediatric cardiac surgery in SIG Kids Toronto, and also in pediatric cardiac surgery fellowship in Boston Children's Hospital. Thank you, Professor Tirapong, for giving us this talk. Please carry on.
Thank you for the organizing committee for inviting me to this fantastic webinar. I am a pediatric cardiac surgeon from Bangkok. I have nothing to disclose related to this talk. I will start with a case example. An 11 days old newborn with hypoplastic left heart syndrome with restricted ASD presented to our unit after birth. The patient underwent Norwood operation with modified BDT shunt 3.5 mm and had difficulty in coming off the bypass and maintaining blood pressure after the surgery, despite good amount of inotropic support. The echo showed depressed ventricular function without other significant residual lesions. What is the appropriate management in this situation? We will get back to this patient later. These are today's topic. I will cover from initiation to weaning, focusing on the perioperative setting. What is an ECMO? It is a form of extracorporeal life support, or ECLS, that evolved from cardiopulmonary bypass but can be used for a longer period of time with mostly partial support. This table shows the difference. The main difference of ECMO and usual cardiopulmonary bypass is outlined here. Different mode and configuration is possible with ECMO, but the support is afterload dependent due to the difference in pump head. The circuit is closed and the lower coagulation level is used during the run. The ECMO support is organs, but not cure the pathology directly, just buying some time. ECMO has two main modes of support: veno-arterial VA and veno-venous VV. Indication of ECMO. Besides refractory cardiorespiratory failure, ECMO can be used for resuscitation, procedural support, and bridging for longer-term heart failure management, such as transplantation or ventricular-assisted device. In post-cardiac surgery setting, ECMO can be used in transition directly from the bypass or used later after successful cardiopulmonary bypass separation or in eCPR setting. The absolute contraindication is now become less and less. Only very poor prognosis will be an absolute indication in the current era. For the selection and timing, the available studies are largely case report and case series. The idea is early support is better, and the decision should be made by multidisciplinary team. The ECMO will be connected to the patient cardiovascular system through the cannulation process, and the machine will provide blood flow and oxygenation back to the patients. Within the ECMO circuit, we can divide into negative pressure region that locate pre-pump on the left side of the picture, and the positive pressure region post-pump on the right-hand side of the picture. There are three sites of pressure measurement, namely P1, P2, and P3. P1 is located in the negative pressure. P2 is post-pump pre-oxygenator, has the highest pressure in the system, and P3 is after the membrane before entering the patients. Delta P is stand for transmembrane or transoxygenator pressure gradient is equal to P1 minus P3. Additional monitoring and safety equipment attached to the circuit is depicted in this diagram. The bridge is a connection between the drainage and return tubing limbs to aid weaning and to allow higher flow rate through the circuit, preventing clot formation for small patients. An example from the real patient. The care team should be familiar with the circuit components. More detail about individual ECMO components. Cannula is the interface that connects the ECMO to the patient's cardiovascular system. The drainage is usually coated in blue, and the return is usually coated in red. The dual lumen cannula is used only for VV ECMO. The multi-stage is available for a larger patient. The care team should know the tip characteristic and visibility in the X-ray because the tip position will be determine the circuit flow. The size of the drainage cannula is the flow limiting factor of the circuit according to physics. Too small cannula will provide less flow and at risk for hemolysis if you drive high flow with high RPM. But the bigger cannula is associated with more vascular complication and distal ischemia. The recommended size will be based on the patient size. The size can be selected based on the blood flow needed also. The centrifugal pump is afterload dependent and is also airlock susceptible. A flow meter is always required. Example of different pump heads for an ECMO. Of notice, the MIDOT pump has max speed at 10,000 RPM, while the others is max at 5,000 RPM. The oxygenator provides gas exchange for blood, and it is main site of clot formation. CO2 removal rate can be adjusted with sweep gas flow rate. FDO2 stands for fraction of delivered oxygen that apply to the oxygenator. This is the different oxygenator models. The circuit tubing made of PVC is the major site of lipophilic drug sequestration, so higher dose is required for the majority of sedative drugs such as propofol, fentanyl, and midazolam. The ECMO mode. This diagram shows the blood flow direction in normal heart. With VA ECMO application, a part of venous blood is bypassing the native heart and lung to the ECMO machine and return to the patient's arterial system, making two parallel heart-lung circuits that supply the body. While in VV ECMO, the red blood is pumped back into the right heart and dysfunctional lungs, so the heart is responsible for deliver all the cardiac output. Thus, no cardiac support for the patient from VV ECMO, but VA ECMO provide both heart and lung support. Cannulation for ECMO. Choosing the vascular access depends on many factors: patient age, size, anatomy of the cardiovascular system, flow needed, lung function, and the patient comfort and degree of urgency. In children, the site of peripheral cannulation based on the patient's age. Central cannulation mostly used in the post-cardiotomy setting with a cause of bleeding. One advantage of central cannulation is greater degree of support without compromising distal perfusion with a large cannula. Heparinization prior to cannulation is the must, even if the patient is coagulopathic, and you have to allow adequate time for heparin circulation within the body before put the cannula into the vessel. Otherwise, you will form nidus of clot within the cannula, and the circuit edge will be shortened. Example comparing central and peripheral cannulation for VA ECMO. Some authors advocate sternal closure with central ECMO to reduce bleeding risk and infection risk. In small patients, peripheral cannulation achieved via the right neck. For VV ECMO, except for the use of dual lumen cannula, the circuit depends on two-side cannulation involving at least one femoral access. So in very small children, VA ECMO will be an alternative even for pure respiratory support. Two-side VV ECMO cannulation is possible for patients under 10 kg by swapping the drainage from the groin to the neck with the cause of femoral vein occlusion post-decannulation. The flow rate per kg is much larger in children when compared with adults, and because greater extent of hemodilution in small patients, the blood prime is necessary. Surgical cut-down is mandatory for pediatric neck cannulation. The X-ray and echo is needed to confirm the cannula position. The tip of venous cannula should float in the RA, and the arterial tip should be located within the carotid artery. For a large patient, the groin cannulation can be done with caution regarding distal limb perfusion. A use of chimney graft configuration or anti-gate fold limb perfusion catheter can be used to prevent distal limb ischemia. For central cannulation, usual heart-lung bypass cannula that we use during the cardiac surgery can be used as an ECMO cannula. The next topic is the ECMO maintenance and weaning. After cannulation, the following checklist must be completed before start the flow. We start ECMO at low flow and gently increasing to the target flow. According to the flow needed, the pump speed is adjusted and sweep gas is tuned according to the patient arterial blood gas. During the maintenance phase, certain aspects have to be managed daily: patient, the circuit. As the ECMO-related complication can occur at any time point, the team should be kept looking for the window to discontinue the support before the serious complication happen. The ultimate goal for support is oxygen delivery. In VA mode, the total cardiac output is provided both by ECMO and the patient's native heart and lung function, while in the VV mode, the patient's oxygen consumption will be limited by amount of blue blood that drawn from the circuit, so we have to minimize the recirculation and maximize the flow. The target flow largely depends on the patient size and physiology. Blood lactate and mixed venous saturation should be checked regularly to ensure the adequacy of organ supports. To optimize oxygen content, the hemoglobin is usually kept high with reasonable coagulation profile to avoid broad thrombosis and bleeding. The circuit should be checked every shift for cannula position and circuit cut. Circuit pressure should be monitored and recorded so we can spot for the change. The main indication for circuit change is thrombosis of the oxygenator or clot within the tubing. In VA ECMO for cardiac support, the sign of native heart recovery triggers the weaning process. With less support requirement, try-off is conducted with a clamp try with full anticoagulation maintained. Alternatively, pump control retrograde try-off or piccato can be used with certain ECMO pump head models. The heart will eject the blood via the atrial cannula through the ECMO pump as an AV shunt and flow regulator, and the blood will return to the patient with the venous cannula. The tubing clamps should be available at bedside all the time for circuit-related emergency. If the pump is stopped spinning in VA mode, retrograde exsanguination can lead the patient to cardiac arrest within minutes, so the clamp should be applied to the circuit until the troubleshoot had been applied. Because of being afterload dependent, any obstruction in the circuit will result in low flow. The pressure change within the circuit will hint the cause of low flow. For example, return cannula kinking. The P1, P2, and P3 will be higher than usual. The management will depend on the etiology. Bleeding is common post-cardiac surgery ECMO. The common site is from around the cannula, atrial. Might need surgical repair. The heparin can be whole with high ECMO flow to reduce the medical bleeding for several days. Whenever you see shattering of the venous line, suck down is suspected. The mechanism is vessel or atrial wall is sucked against the drainage holes of the cannula and block the blood flow. To address the problem, the pump speed is temporarily reduced to free up the holes, followed by giving volume or adjusting the cannula depth before increase the RPM back to the targeted flow. Because the VA ECMO reduced ventricular preload but increased the ventricular afterload, to prevent LA hypertension, LV ejection must be maintained with inotropes. If the ventricular function is very poor, mechanical venting might be needed to prevent LV stasis and clot formation. This shows transapical LV venting via mini thoracotomy. The vent is then wired to the venous tubing of the circuit. LV vent can be inserted via the left atrium or via the right superior pulmonary vein in central ECMO configuration. The last topic is special consideration in congenital heart disease patients. Abnormal systemic venous anatomy is taken into the consideration when choosing the circuit configuration. Also, the presence of systemic 2 pulmonary shunt will allow the flow runoff from the aorta to the lungs, resulting in an inadequate organ support. Management can be either shunt restriction or run the ECMO at high flow to compensate the runoff. We typically target the flow 150 to 200 ml per kg per minute in this setting with patent systemic 2PA shunt without shunt occlusion. In the patient with Glenn anastomosis, the neck cannulation cannot decompress the heart directly as the SVC is no longer connected to the heart. Additional IVC drainage for cardiac decompression during VA ECMO support might be required through abdominal IVC. Back to our patient. Without significant residual lesions, decision was made to place the patient on VA ECMO support for raised myocardium. The BTT shunt was kept open during the ECMO run, and the patient was decannulated successfully 3 days later. In summary, the use of ECMO in perioperative cardiac setting revolves around procedural support and post-cardiotomy myocardial dysfunction. The central VA ECMO is more common in small post-operative patients. Oxygen delivery adequacy and myocardial unloading is crucial for the success, And don't forget to take into the account the vascular anatomy for the cardiac patient for the optimal support. Thank you for your attention, and I am very happy to take any question or comments.
Thank you, Dr. Thirapong, for a very insightful talk. And I think we got our answers from the Q&A that was posted earlier for the poll questions that were posted earlier. Now I'd like to hand over to Dr. Angela Tan, who will introduce Professor Sunirath. Dr. Angela, please take over.
Hi, everyone. It gives me great pleasure to introduce Professor Sunirath from Saripong. Professor Sunirath is professor in anesthesia, and she works in the Department of Anesthesiology and Critical Care in Saripong Hospital, Bangkok, Thailand. Professor Sunirath is a familiar face to all because she was previously president of the ASPA Society. She also holds a qualification and diplomat of the American and Thai Board of Anesthesiologists, a certificate of fellow in research in cardiac anesthesia, cardiac, and as well as cardiac critical care. She was also a fellow previously in the pediatric anesthesia at Boston Children's Hospital. Professor Sunirath's talk in two parts. The first part of the talk focuses on perioperative eCPR, and the second part of the talk focuses on ECMO for non-cardiac surgery. As previous, we will start off our, before we start our talk, we will have two poll questions for the first talk. First poll question, what is the primary purpose of extracorporeal cardiopulmonary resuscitation, eCPR? You should have the poll in front of you. Please answer, please select your answer according to the poll. Right, you'll end the poll now. Okay. So the answer to this question is primarily to restore circulation as well as gas exchange. And from the poll results, you can see most participants actually got the correct answer. Right, we'll go on to the next poll question. What is the most important factor for the outcome of eCPR? There are four options: arrest time before maximal flow of ECMO, select a patient with good prognosis, maintain good ECMO flow, or D, good post-cardiac arrest care, i.e. low oxygen saturations, target temperature control, as well as normal cardia. Right. Okay. So it seems like there is a tie between deciding whether it is arrest time before maximal cardiac flow or good post cardiac arrest care. We will now listen to Professor Sunirath's talk and see whether we get more insights from it.
Good afternoon, Mr. Chairman, ladies and gentlemen. My name is Professor Sunirath from the Department of Anesthesiology, Virat Hospital, Melbourne University. I have to thank the Paediatric cardiac section of the ASPA for inviting me for this talk. My talk today is about pediatric extracorporeal cardiopulmonary resuscitation. Extracorporeal cardiopulmonary resuscitation, or we call eCPR, is the application of ECMO in patients where conventional cardiopulmonary resuscitation are unsuccessful in achieving a sustained return of spontaneous circulations. Sustained loss is when chest compression are not required for 20 consecutive minutes following cardiac arrest. The primary purpose of the eCPR is to restore circulation and gas exchange, that is to restore perfusion. It provides time for us to rescue the patient more and correct the primary cause of cardiac arrest. In pediatric patients, the survival rate up until hospital discharge varying from 8 to 80% and more successful in cardiac patients that might because it happen in near the or in the cardiac operating room. But anyhow, in the adult patient, more than 85% of the survivors have neurological deficit. That's why we need to find the good candidate to do this ECPR. eCPR is a time-sensitive complex intervention that requires teamwork, very low and well-trained healthcare provider. Times before starting the maximum flow of the eCPR is very important, and we need to have the high quality CPR before that. That's why we should call for the eCPR in 10 to 15 minutes of the unsuccessful conventional CPR, because it takes time to set the personnel and set the system. And we should select the patient with good prognosis, especially when with the witness arrest or maybe with a high quality CPR up until we start the maximum flow. This is a study that shows the prognosis or the goal that we can do and to predict the survival and neurological outcome of the patient. But usually we like to reach the maximum flow of 40 minutes, but anyhow they still not have standardized, so they also recommend that should be less than 60 minutes up until cardiac arrest until we reach the maximum ECMO flow. Come back to the patient selections. Patient factor is important. That should be the young age. Hypothermia is good. It have reversible pathology. Absence of previously known life-limiting comorbidity, and no limitation to use ECMO, for example, aortic regurgitation. For more prognosis, the patient should show signs of life during conventional CPR. For example, initial cardiac rhythm of VA, VG, of PA, and internal CO2 more than 10 millimeters during CPR or intermittent ROC. Most of all should have high quality CPR before we initiate the ECMO. And this should be on the VA ECMO. Can we go with the peripheral ECMO or central ECMO if it's in the cardiac operating room? Cannulation, because it is the pediatric patients. For the neonate, infant, and small pediatric patients, we like to go with the carotid internal ring. So the patient need to be intubated before. For the bigger kids, we can go with the femoral vein and femoral artery for the peripheral ECMO, but we need to have the adequate perfusion to prevent the limb, especially ischemia, especially in the pediatric patient who had the small vessels. And we need to confirm the cannula positions, one in the vein, one in the artery, before we running ECMO to avoid inadvertent non-physiologic. And from the study, surgical experience might be more better than in percutaneous in the pediatric patient, faster. And this is the ACLS modification and starting ECMO. High quality CPR should be applied throughout the entire resuscitation up until we reach the maximum ECMO flow. And if we had only the one the patient, we have to be very careful to do the defibrillation while we have the wire in. And after priming the circuit, and then we hook to the ECMO cannula to prevent the air bubble in the circuit also, and gradually increase the ECMO flow up until we reach maximum flow. Once we reach the maximum ECMO flow according to the patient age, we can stop the mechanical compression and discontinue others more if we have adequate circulation, especially the vessel pressure and inotropic. And we rapidly, otherwise we will have, we might have the blood pressure going into the dangerous kind. more important than that because this is in the perioperative period. So we have to be very careful with the anticoagulant. Usually we like to bolus with 1 milligram of the unfractionated heparin per kilo. But anyhow, we can go, personally, I like to go with only 0.5 milligram per kilo of heparin at that point to prevent more of the bleeding. And then we titrate the heparin to keep the ACC about 180 or APC ratio about 1.5. Sometimes we just do only the bolus and do not give heparin for 1 or 2 days to prevent the bleeding. And this is a pediatric patient. Also, don't forget blood plasma or albumin to prevent hemodilution and anemia. And when you give blood back to the kids, have to be careful about hypokalemia. We might need to add some kind of calcium and bicarb to this also. And don't warm the solution too much because this is the post-cardiac arrest care. And this is the also guideline for adult eCPR, but we can modify to our pediatric patient that we need to check and no air bubble before connect to the patients. And more of the immediate post-cardiac arrest care with this patient, we need to reassess the cannula again to confirm by using fluoroscopy and echocardiography that the tip of the drainage cannula should be in the right apron and monitor cerebral perfusion by monitor the knees or right side upper extremity if we can and titrate the vessel pressure down according to the age of the patient and the not higher than 80 millimeters mercury to prevent the LV dysfunction and titrate the sweet gas to avoid hypocarbia, titrate FiO2 to avoid hyperoxia, PaO2 less than 300 millimeters mercury, oxygen saturation around 96 to 98, and monitor entitled CO2 is better for us that can predict the native cardiopulmonary circulation. And further care within the first few hours, we need to check blood flow stability, especially in the post-cardiac arrest patient and in the surgical patient, because somehow we may have some kind of bleeding that decrease blood volume in the ECMO and in the patient. We have to keep blood and stop that kind of bleeding. And or maybe the patient might have some kind of pneumothorax or cardiac tamponade that need to put some chest drain in. And if the patient had rhythm coming back, they had the perfusion rhythm that is good for us, that will prevent the LV dysfunctions. And if we have LV dysfunctions, we may have to correct it to prevent pulmonary congestion or pulmonary edema. Or this can destroy LV function by putting the LV vein directly, as Dr. Cheripong said about that, or maybe we need to do a septostomy or implant about that. Aortic balloon bundle network for this patient because the aorta did not stiff enough. And further care within the first hour, sometimes we may have to titrate the PEEP up to prevent LV fluid, pulmonary edema. And because we have the decreased pulmonary blood flow at the first time, so with some kind of decreased ventilations to keep the normal cardia. And if we don't have the entitled CO2, it indicates that it might have absent native circulation. Avoid hyperoxia and keep temperature at 36 degrees for the central temperature for 24 hours as per the ACLS guideline in the post-cardiac arrest scan. And if everything's stable, we need to find the cause of the cardiac arrest and correct the acid and low perfusion condition. And if everything has been correct and the surgery the patient condition coming back usually take a day or two, and we can kind of slowly weaning the patients. Usually, I like to sit with the ECPR about a day at least to make sure that everything coming back and correct the primary cause, especially in the pediatric patient, that most of the cardiac might come from the uh, hypoxemia, that we like to correct that one and make sure the kid can breathe, and that kind of hypoxemia might not coming back again. Or in the patient with cardiac surgery repair and have cardiac arrest, I like to wait for about 48 to 72 hours to make sure that everything is all right and gradually increase the ECMO flow, and slowly about 0.25 or 0.5 by a little bit increase of the inotropic, and then stop the ECMO, gradually stop the ECMO flow. Or because of this patient in the pediatric patient, we can go with the VA ECMO. In the case that we have to deal with the oxygenation, like a serial pulmonary aspiration, serial drowning of the pediatric patient, so we decrease the FiO2 and look at the lung compliance by doing the VV ECMO to behave like a VV ECMO at that point. So in conclusion, pediatric eCPR is an important rescue procedure in unsuccessful conventional cardiopulmonary resuscitation. This is a time sensitive. If we do take conventional cardiopulmonary bypass in cardiopulmonary resuscitation in the good candidate to call the eCPR within 10 to 15 minutes. And at that time, we like to reach the maximum ECMO flow of 60 minutes. That's why it takes time to prepare the equipment and human. And we need to think of the patient selection. Should be in the patient with good prognosis and survival and neurological outcome. We ECMO for the pediatric patients because the vein is small, and continue effective CPR until reaching the maximum flow. Looking at the cannula to prevent the unphysiologic running. Don't forget to give blood, fresh frozen plasma, and albumin in the prime solution, and carefully titrate the anticoagulant, especially in the surgical patient to prevent the complication of the bleeding, and do the basic post-cardiac arrest care to avoid hyperoxia, normal cardiac temperature management, and correct primary cause, and stop this eCPR or ECMO when native cardiac and respiratory function coming back. Thank you very much for your kind attention.
Thank you, Prof. Sumirat, for the first talk. Okay, before we move on to the second talk, we have a few more poll questions. The next poll question is, when utilizing ECMO for non-cardiac surgery, which of the following are important? The four options that we have are: 1, selecting the right type of ECMO support; multidisciplinary team discussion; clear plans for pre and post procedure; perfusionist available throughout the process. Right. So, in this question, actually, all the options are important, and we will, in her talk, we'll go on to understand why. We'll move on to the next poll question. What is or are important issues that need to be considered about perioperative ECMO? A, breathing; B, team approach; C, transportation; type of ECMO, and feasibility of using ECMO. Okay. And so the two answers that are relevant to this are one, leading, as well as a multidisciplinary team approach when doing these cases on ECMO. Before we go on to the next talk, I would like to remind everybody that you can actually post your questions in the Q&A section. And if there are any other questions, if there are any questions, please post them in the Q&A section. We will either answer them on the Q&A itself or towards the end of the talk.
Good afternoon, ladies and gentlemen. Come back again to another topic, perioperative ECMO for non-cardiac surgery. Perioperative ECMO is the modification of ECMO in the perioperative period. This can be used in elective surgery, for example, surgery that needs cardiopulmonary support, that conventional support or techniques would not provide adequate cardiac output or oxygenation. For example, in difficult airway surgery or neurological surgery. Or it can be used in the emergency situations, like in the operative cardiac arrest, in the situation of severe hypoxemia or severe bleeding. The most important is what we need to know. We need to understand the basic concept of the ECMO support. Pick the right type of ECMO support in that situation. But for pediatric patients, especially in the neonate or small infant, VA might be the choice because pressing the venous line is difficult. And know the limitation and complication of ECMO support. For example, the aortic regurgitation, and also the most serious complication of ECMO support is bleeding because we need to use heparin. We need to know the process of initiation, maintenance, and weaning, and know the complication as I mentioned before. And we need to have a good plan for weaning off, whether during or after the need during procedures or after procedures, or we need to continue the support after the procedures, and where will the patient need to be after procedures. For the pre-ECMO plan, we need to have a clear plan of everything, especially where we can get the machines, where the machine will be run and sit in the room, and time and interaction before we place the ECMO, because sometimes we can do the surgery at that point, and in a certain point we bring the ECMO in. And have a post-procedure plan, whether we can off the ECMO and send the patient back to the floor, or maybe the patient needs to be in the ICU after procedures. And if the patient is on ECMO or needs a post-op ECMO support, where can we decannulate the patient and time that should also be discussed. For elective surgery, for pre-operative planning, we need to have a team discussion. In the discussion, we should have a comprehensive discussion with a detailed plan among primary referring physician, surgeon, anesthesiologist, perfusionist, and intensivist. Perfusionists need to be available throughout the process to help us. Sometimes we might need pre-procedure simulation in a very difficult situation where the machine places and where the cannulation, what time, and other thing else. The most important issue that should be discussed is the type of ECMO, cannulation site, anticoagulant, time overlap between conventional and ECMO support, and after procedures plan. We need to pick up the right type of ECMO support, VV or VA-ECMO, as I mentioned before. For the small infant and neonate, usually we use VA support and modification of VA support despite the need only oxygenation support. For the cannula management, we need to discuss about this before. It depends on the age of the patient, size of the surgical procedures, and cannula size also need to be discussed because sometimes it needs for a very short period of time. We might can use a small cannula, but need to run it effectively to prevent the reparation after the ECMO placement. Anticoagulant is the main issue for the perioperative period because it might cause some kind of bleeding. It also depend on the type of the surgical procedures, type of the ECMO flow rate. Sometimes we just use the bolus 0.5 to 1 milligram per kilo, that is 25 to 50 units per kilo or less in the priming. And we need to talk about contest strip because sometimes the procedure is very short. We might not need the drip. And if it's very short procedures, we might need protamine to reverse the heparin dose. And anyhow, we also need to monitor such as point of care ACT or maybe APTT that should not above 1.5. ECMO priming solution, because this is a pediatric patient, even we use it for a short time, we should keep the hemoglobin as the patient needs. And don't delude the patient that we might need to give fractionation plasma, albumin, or platelet. And we need to warm the solutions or slightly warm in the eCPR. And we should match more blood and blood component in case of bleeding or unexpected bleeding that might cause the ECMO stop with the loss of the volume. What need to be discussed, the main discussed during the procedure, especially in the airways of surgery, that any change of the ET2 ventilator setting should be checked with us. And if it can be used with conventional, at that point we might can decrease the ECMO flow and stop the ECMO. And we need to know the detail of the procedures because if they have a lot of bleeding or blood loss, we might need to give blood. Or they have a bleeding a lot in the side, we might need to decrease the ECMO flow. It depends on the time that need to be discussed closely in the team. And the one that we afraid a lot is venous embolism because the ECMO machine don't have the reservoir. So before we hook the ECMO to the patients, we need to de-air completely. And if the procedures had some blood, some air, not the blood coming, we need to draw all the air out to prevent the stop of the ECMO. That will be very dangerous if the patient needs cardiovascular support by the ECMO. What should be monitored? Arterial line should be on the right arm. We need to monitor the anticoagulant effect on the bleeding on thrombosis. ECMO function, ECMO speed, FiO2 and sweep can. And also perfusion of the body apart from the blood pressure is urine output, SiO2 and lactate if it's a prolonged procedures and bleeding procedures. Transportation is very important also because sometimes we need to support the ECMO afterwards. That's why all the team need to know what happened and the ECMO machine need to have battery. We used to have a patient after procedures that had ECMO and battery stopped. Why? We transfer the patient back to the ICU, yet that we need to have the hand cranking of the machine. So we need to check everything and oxygenation. And we should not transport if the patient is not stable. And how about the patient who have to be on ECMO and come for non-cardiac surgery? What we need to know the indication of that ECMO. detail of the ECMO support and complication occurring with that support, detail of that non-cardiac surgery, what they want to do, especially when they come for termination of the ECMO. We need to make sure that the organ that we support coming back, plan for other support, for example, airway support. And if we don't know, please consult the expert. I have a patient, 2 years old, preterm baby, 1.9 kilo, with complete trickling. He came for sliding tracheoplasty and developed severe hypoxemia after we transferred the patient to the ICU. So they go VA ECMO, carried to internal jugular. ECMO was inserted and run ECMO successfully. This patient need to come for DL and have the laser of the airway many times, at least 5 times. And we need to transport the patient back and forth. And every time we need to make sure that the transportation team is all right. And the who taking care of him in the operating room, no, we need to have a perfusionist. And also with these patients, we have a plan to place the small endotracheal tube. So this is a plan. And finally, he came and met me in the operating room again. So we talk about endotracheal tube and coagulation and how we ventilate the patient with non-ECMO support. And finally, we can take off the ECMO support at that point. But unfortunately, because we used the heparin, this baby has intracranial bleeding, and this baby also have to come for craniotomy. That I also help with that craniotomy. And finally, the kid did well, and currently he went back home. This was successful with a clear plan between our team, cardiologists, cardiac surgeons, ENT men, and perfusionists, intensivists also. So in conclusion, perioperative ECMO is the application of ECMO support to help with the cardio and our respiratory support in the perioperative period. You need to know the basic things for the ECMO support. Pick the right time, good monitoring, with the complications, and stop support when all the conventional management can help. Team approach is very important. Thank you very much for your kind attention. I'm happy to answer the question. Thank you very much again.
Prof. Sulirat, for the very interesting talk. I think my biggest takeaway from the last talk that you did was that risk of bleeding is high in patients coming in for non-cardiac surgery but on ECMO. And the other thing that is interesting or important to take note that it's not like a cardiac surgery where people are used to being around an ECMO circuit. And so a stimulation before doing a non-cardiac surgery on ECMO is also as important to make sure that where things are, where people to stand, where the ECMO does. So to me, that's the biggest takeaway from my last talk. Thank you very much, Dr. Okay, so now we will actually move into the Q&A section. If you have any questions, please do type them in the Q&A box, and we will try our very best to answer them during this segment of the talk. So if you want to start off with the first question for the speaker.
Yeah. Thank you, Prof. Sulirat, for the very insightful talk. So for me, when I see patients going on ECMO, both in cardiac and who come for non-cardiac surgery, one of the most troubling factors is how do I manage anticoagulation? So for Prof. Tirapong, I want to ask, now you have, like you presented the case, you have a patient who probably had a long cardiopulmonary bypass, and now you have decided to go on ECMO. So do you allow any protomin to be given for this patient, and how much correction of anticoagulation do you allow before going on ECMO? Like if this patient, my question is like, if this patient had not gone on ECMO, I would have probably given all factors. I would have given FFP, platelets, maybe cryoprecipitate, all of them before transferring the patient. But now that this patient is going on ECMO, how much of correction do you do before going on ECMO? Second, for anticoagulation, I would like to ask Prof. Sunirat. Now, as you presented in your case, this patient had intracranial bleed. Now, if you have a neurosurgeon who refuses to do the operation without reversal of heparin, or how do you manage such a case who's coming for intracranial bleed?
Thank you for a very interesting question. We will start discussing how to manage directly transition from the long aggressive surgery to ECMO. So for sure, first, the principle of the surgery is to hemostasis during the start of the surgery, not at the closure. So you don't know which patient will turn into ECMO candidate at the end. So you first start meticulously dissect before you heparinization, and then when you end up have to put the patient on ECMO, you have less bleeding to start off, and then adjunct you can be used, for example, sealant and proline, basically to stop all the surgical bleeding as much as you can. And one of my tricks that my boss tried to do, if the hemodynamic allow to briefly come off the support, and now you can reverse all the heparin with all the products and protamine. And then if the patient is borderline, you can put the patient back on with an bolus, but you have some clot that will stop majority of the bleeding. And one thing that if you already start the flow, or in the case that you cannot stop the support at all, run the ECMO with a little bit high flow rate, you can stop heparinization for quite good amount of time, maybe several days before the circuit start to clot off. And you have for my personal experience, I have several cases that we have bleeding from mediastinum, despite all the effort we try to correct. So eventually we have to stop the heparin for weeks, and the circuit run pretty well for surprising 2 or 3 weeks without any heparinization. But we always give platelet and products every day, basically. Yeah, but so my point is you can stop heparinization during the ECMO with high flow, and of course higher risk of circuit clot. But you can change the circuit if it clot, but if the patient continue to bleed, the patient will eventually die because you cannot run the support.
Prof, how high is the high flow that you say when you're talking about high flow, especially the pediatric patient?
Yeah, so it depends on the model of the oxygenator. You have to look at the specification of that oxygenator, what is the maximum flow rate, and you can try to run at second half of the maximum flow, something like that. And then another factor is if your institution use bridge within the ECMO circuit, it will eventually increase the total flow through the membrane and the pump. So it will increase the overall flow through the ECMO, but everything, not 100% through the patient. So you can have more flow. Yeah.
Professor, the second part of the question, as you said, you had this patient who went in for intracranial op, means he had intracranial bleed. Now, if I have a neurosurgeon who says, okay, I won't operate till you reverse the coagulation, so how do you manage such patients who come for ops, non-cardiac ops?
The neurosurgeon hates bleeding. So
yes,
I will do the same thing as Dr. Theopong. We stop the heparin and we increase the flow and give the blood product, including the tranexamic acid, about 20 milligrams per kilo. But I'm a kind of afraid about factor concentrate, so we didn't use any PTC or fibrinogen concentrate. And we stopped the heparin for a couple of days, and it's fine. I don't know why, because some of our patients did not use heparin, and I used to ask Dr. Thirupong that we can stop and go with the high flow. It really work. Go with the high flow and stop heparin until everything go all right, and then we start it again. But we have to watch closely for the clot, and we didn't see it. We stopped. I used to have a patient run on ECMO for almost 2 months, and we didn't use the heparin for almost 3 weeks, and it still be all right. It's depend on the flow.
Yeah, sorry, just to clarify, you mentioned that with the patient, you stop the heparin. Do you use PCC or you avoid PCC?
For usually, for the patient who we use the ACT and also APTT ratio also, because sometimes with the ACT in the pediatric patient and they have a lot of confounder. So I discussed with the hematologist and he suggests that he liked the APTT, even though it's a pediatric patient. They have a lot of confounder. Even TED or Lotem did not have the right answer also. So we picked the APTT ratio not above or not below 1.5. And if we want to reverse it, we go with APTT almost 1.
One thing that my personal feeling is we are afraid of protamine. If the patient is currently run on the ECMO, I try not to give any protamine. I will wait until the heparin naturally wear off rather than correct it very fast. I believe that can lead to clot off very quickly.
Yeah, I agree with Dr. Thirupong also. We afraid a lot about protamine. We use it after we off ECMO and give protamine, but during ECMO, we afraid about protamine or any complex concentration, protamine complex concentration, because we afraid of the minus clot or anything. We didn't use it.
So just to clarify, in both settings, you will not use protamine to reverse the anticoagulation when the patient transits onto ECMO, but you may continue giving blood products to correct the coagulopathy. Is that what I'm hearing so far?
Yeah, we give blood product. Because if you give protamine complex, sometimes it overcorrect the patients. That's why we go slow. And because I have a lot of study in the protamine complex concentration, but it's a kind of a little bit danger, especially in the pediatric patient, that sometimes we overcorrect that. So with the small circuit, with small cannula, so I am afraid to use that during ECMO.
Prof, I know that in your institution, there is use of prothrombin complex concentrate, so PCC, which is contains two factors 2, 7, 9, 10. In patients who are on the ECMO, is that something that you will avoid?
Yeah, for me, I avoid how Dr. Thirupong, are you avoiding PCC? We use it after cardiac surgery, but not during ECMO.
Yeah, agree. We try to correct everything with just product.
Thank you, Prof. Thirupong, Prof. Sunil. Another question I wanted to ask is, what is your weaning protocol, and do you wean? Are you happy to wean all of them in ICU, or are there some patients that you prefer to bring to theater to wean and to decannulate?
I'm going to answer this question first. So what I have seen is in our hospital, we do not use the bridge within the circuit. So we cannot put a clamp to the circuit for a really long period of time. Otherwise, it's going to cut off everything within 5-10 minutes. So we will wean by gradually decrease the flow and to echo serially and try to decide what is the right time point and we take the patient to the theater, or we bring the OR team to the bedside because we have to reconstruct the vessel, and that's how we did that. But based on my training experience in the sick kids, they use a bridge within the circuit, so they can do the clamp try with circuit running through the bridge. That how they keep the circuit from clot off. And then when every 5 minutes during the clamp period, they allow flushing through the cannula, so prevent clotting formation within the cannula itself, and we'll briefly put the patient back to support, and then 5 to 10 seconds, they clamp again and let the circuit run through that bridge. So that's how they do it.
So for me, we do both, and we gradually wean, like Dr. Thirapong said, that we don't have the bridge. So we gradually wean. If we support for the cardiac, so we wean the flow. And if we support for the wean the flow is a little bit dangerous because sometimes we may have some clot with the low flow. But for the one who we support for the respiratory system, so we go with the adequate flow and wean the FiO2, and we can do two things, that we can decannulate in the ICU, or we can decannulate in the operating room. My last patient, we decannulate in the operating room with that complete trickling that we like, because we do many things at the same time. At that point, we do the DL, change the tube, and wean the ECMO at the end. So we did it in the operating room. But in my ICU, we have everything. Like in the operating room, we have light, we have gas source, we have sterile room. So if we have everything, we can do decannulation in the ICU instead of have to transport the patient in and out.
Thank you, Prof, for the answer. Okay, Prof, I have another question for you. What kind of conditions or surgery would you do on a VV ECMO versus a VA ECMO?
VV ECMO, because the kit we use VA ECMO, if the older one, for example, the surgery of the airway or thyroid gland that is very big, and that we do the VV ECMO. But we have one patient, unfortunately, we should set the VV ECMO before doing the thyroid surgery, but we did not do that. And finally, the patient had severe hypoxemia, cardiac arrest in the operating room, and then we placed eCPR. That take times, and finally the patient had brain dead. So if everything that we need to do is right from airway is important, we should plan ahead.
I have a trick for non-cardiac use of ECMO. So if you're not too sure that we really need the ECMO support, and we're afraid of bleeding when you put a patient on ECMO and do some kind of non-cardiac surgery, one thing that you can do is you set everything up in the room, wet prime the circuit without blood or products, and then you discuss with the team regarding the cannulation strategy if we have to put a patient on ECMO, and then you just placing wire or central line just give you like a quicker option to really put a cannula in the patient, but without actually cannulate before the procedure. And then if something happened during the surgery, you can quickly put the patient on ECMO.
Yeah, I agree with Dr. Thirapong, because in the CPR, you need to make sure that the wire in the right position. That take times, especially when you do the cardiac compression. You have to do modification of the transthoracic echo, like a rescue echo, or sometimes we put the transesophageal in that take times. So we used to have one patient that we put the wire in vein and vein. That is the very unphysiologic eCPR, and finally the patient passed away also. So put the wire in, make sure the wire in the right position, and then go from there. That will save time.
Thank you, Prof. You had mentioned that you check position of cannulas in each shift. And other thing you had mentioned means I wanted to ask about LV afterload use can increase. So do you do how frequently do you do echo, and how do you check the cannula is in position in every shift?
Yeah, ask Dr. Thirapong first.
Yeah.
I think the cannula can be position can be altered only by depth, so it can shift inward or outward. So just by looking from the outside, you can exactly tell what is the actual change from the first day. So what I recommend you to do is on the first day of cannulation, you have to take a picture, put in the chart, and everyone know that this is the initial point that we intend to put the cannula within the patient, and then referring to that initial position, you know what is the change that happened, and then complementary is X-ray. I think the daily X-ray should be adequate because you have to do it anyway. And
Yeah,
so for the echo,
we do the same thing, but sometimes if we are not sure if it's in adult or bigger kid, we put the transthoracic echo, and sometimes we do the transesophageal echo to make sure. But the picture at the first time and the tape is all right, because sometimes the cannula coming out with the bed blood and with some kind of blood it coming out, and we have some recirculation, so we need to look at it every morning, every day, or do the echo when we have the question. But anyhow, to look at the cannula with the transthoracic echo a little bit difficult for us. Sometimes we put the transesophageal in to make sure everything is all right, and make sure that we did not dislodge the endotracheal tube when we pull the echo out.
We have a question in Q&A. The question is, I think it is important when the timing of referral to facility where ECMO is available from regional facility without ECMO is available. What would you give some indices? Example, oxygen index greater than 30 to 40 in a patient with respiratory failure. Refractory cardiovascular failure, even with maximum cardioactive meds such as 0.2 mics per kg per minute of NORAD infusion or so. It might depend on the type of leak.
Yes, I'm presuming the question is actually asking about when would you actually refer to a facility where ECMO is supported when your hospital does not have an ECMO service. So what are the factors or the considerations that you have when trying to activate this person? This is the ECMO from another hospital. I guess before the patient actually goes into actually requiring CPR and decompensating.
Yeah, because ECMO is not available in every place. So if we cannot, then we have to do two things. The first one, for the elective surgery, refer to other center. If we do the eCPR, just go with the high quality CPR and then call for the ECMO. That might take time, but high quality CPR is very important. And how to find the ECMO, it's a little bit difficult also in my country, because just have the ECMO in the bigger center.
I think the criteria to make a decision regarding referral is a little bit looser than the actual put the patient on ECMO criteria, because when the real situation comes and the patient is very unstable and you don't have ECMO in your hand, and it's very dangerous to send the patient to another hospital at that time point. So maybe you have to make a decision a little bit earlier.
Sounds like it really depends on, how far the ECMO center is and what kind of manpower you may have with you, even for transport to get to that ECMO center. So I guess it's not an easy decision to make. Many, many factors come into play when deciding when we should activate ECMO for in a hospital without ECMO support. If anyone has any more questions, do type in the Q&A box. If If not, maybe we get Dr. Tia Tong and Tia Tong and Paul Sunirat. Any other thing else you would like to highlight to the audience with regards to this use of ECMO? And maybe last words in terms of pearls of wisdom for use of ECMO to the audience before we end off our session.
Yeah, Dr. Thirapong first.
ECMO is useful and can rescue the patient, but it comes along with many serious complications. So think it wisely and try to come off with the ECMO as soon as the patient really don't want it. That is my one last word.
Yeah. For me, the eCPR, we need to pick the right time, right person. But I like to stress the high quality CPR first. And then if the patient had a good candidate, call earlier for the ECMO. Otherwise, we will lose the patient. And for non-cardiac surgery, team approach is very important, very, very important. And the plan before. Sometimes we had the simulation, so go from that. That might be the way that we can do more complicated surgery and save life of the patients.
Yeah, I agree. I think we also have situations in our hospital where patients turn sick. And even though our hospital can support a CPR, I think the discussion even before, like the discussion between the multidisciplinary people to decide whether this patient is actually a candidate for eCPR is also actually a good initiating point to have as your patient starts to turn back. So that discussion will then trigger off other discussions as well and may eventually save a life. So early discussion and teamwork is, I guess, is key in this situation. I think you have anything else to add?
One last question. Now, if we have a very high risk airway case or anyone who has potentially can go on ECMO, so how ready are you with ECMO in such cases? Is the team standby in theater and the machine there good enough, or do you have the cannula with the cannulas in? Is that good enough? So what degree of readiness do you have for a patient who can potentially just collapse and go on ECMO?
I think it depends on your institution. If you have a wet prime ready out 24/7 in your hospital, you can bring the ECMO machine into that room, and then perfusionist, ECMO specialist, or fellow, or the cardiac surgeon ready in the room breathing. But if you have no always ready ECMO circuit, there's another topic. Maybe you can bring the machine and the dry circuit within the room, and one personnel ready to communicate. Yeah, and then you can do a speed prime whatsoever.
I agree with Dr. Thirapong, but in my hospital, we depend on the team of Dr. Thirapong technician. They are very, very efficient and very fast. Like the last eCPR that we do it, we can reach the maximum ECMO flow in 40 minutes. And the patient wake up. Did very well. With the high quality CPR and also with the very fast, efficient of the surgeon and the perfusionist. Perfusionist is very important also.
Thank you, Prof. Thirapong. Thank you, Prof. Sunirat. I think today I think I'll go off very confident of how to manage coagulopathy on ECMO from today's talk. It's we have always been a bit scared of turning off heparin, and not only us, also the whole team that we are with. But I think from today's talk, I'll be far more confident on managing these patients, especially when they come for non-cardiac ops. Angela, would you like to close?
Yep. So just a few words before we end today's session. To get the certificate of attendance, please scan the QR code for the survey and the MCQ. Please check that you have correctly entered your full name and email address. The certificate of attendance will be sent upon completion of the survey and the MCQ. You'll also receive the survey and the MCQ link via email the next day, which is tomorrow at 5 p.m. Singapore time. This is just also the reminder for everybody, this is the next talk that is going to come up in April, Central Neurorectal Block reviewing the classics. This will be part of the 10th ASPA Flex webinar that's happening on the 21st of April. So please do sign up for this talk. And again, for everyone that we are available, you can follow us on Facebook, and this recording of this video will be available on YouTube as well. And if there are any other information you'd like about ASPA, on the ASPA website, so aspa2000.com. If you'd like to donate for ASPA's cause in education, please scan to donate. ASPA is a non-profit organization, and our mission is really to foster the highest standards of pediatric anesthesia care in Asia, and to seek your help to donate and help us in our cause. And before we go off, this is in July. ASPA will be held in Kuching. It's still not too late to sign up, so please do sign up. I believe the standard registration has started. We might be a bit late for the early bird registration, but still, please sign up and support ASPA in Kuching, July 2024. Thank you everybody for attending today's webinar, and extra special thanks to our two speakers, Prof. Yatong and Prof. Sunil, for preparing such an informative talk for all of us. I think we all go away with more knowledge about ECMO, definitely from this talk. Thank you very much for tuning up. Thank you very much, Prof. Yatong.
Thank you very much again.